So someone wanted to know a little bit about radiation therapy in neuro-ophthalmology. And basically there are different types of radiation therapy. You need to know in general what type and how much dose we're receiving. So you don't have to know everything about radiation, but you need to know that we basically have stereotactic radiotherapy, we have stereotactic radiosurgery, and we have whole brain external beam radiation therapy. The difference is in the whole brain, you're just delivering the radiation to the entire brain. And that's when we do that usually when there's multiple metastatic disease or you're just doing palliation therapy. In stereotactic therapy, the stereo means we have a focused beam from different directions. That's what stereo means. And taxis means we can pinpoint the localization. And what stereotactic localization allows us to do is pinpoint the radiation onto a single point in space. They're both R, which is radiation therapy. Typically gamma is what we're going to be using. There's usually a gamma source producing the radiation. That's usually something that's radioactive, like cobalt-67. And one is therapy and one is surgery. And the stereotactic radiosurgery isn't actually surgery. There is no cutting. It's just a name for a focused beam, and normally it's a single dose. So you're giving a single dose. So in stereotactic radiotherapy, just like whole brain, it's an external radiation source, and we can collimate the beam with a collimator. So a collimator allows us to focus the beam, and we have a gantry apparatus that goes around the patient in 360 degrees like this to allow us to have multiple ports that we can open and close to deliver the radiation dose. And so when you have stereotactic localization, we can use intensity modulated radiotherapy to change the dose, that is the modulation of the intensity, to deliver a uniform dose at a single location. We can modify the dose that comes from different locations. So in a CT scanner, you have a uniform dose of radiation going in, and your body attenuates that signal, and a non-uniform dose comes out that we can image. In intensity modulated radiotherapy, we are giving a non-uniform dose to deliver a uniform dose at a specific point based on the density of the tissue and the distance we have to travel. So a CT diagnostic is uniform dose in, non-uniform dose out. External beam stereotactic intensity modulated radiation therapy is non-uniform dose in, depending on what we have to hit, to deliver uniform dose to the target. And in stereotactic radiosurgery, we're going to try and give that all at once, and you might fractionate it into 1 or 2 fractions. But in stereotactic radiotherapy, we're trying to reduce the side effects by reducing the amount of dose that's given in each session. So you might have 10 or 14 sessions of 200 centigrade each to generate 2000 centigrade for orbital treatment for thyroid eye disease, for example. Or if you're giving 54 gray total dose, you might fractionate that over a much larger period of time. It's that fractionation that reduces the toxicity. In stereotactic radiosurgery, single dose, but it's much more convenient. And in stereotactic radiotherapy, we can conform the shape of the lesion to the shape of the beam. And so you might end up with a kidney bean shaped tumor that's around an important structure like my optic nerve or my pituitary. So we want the dose curve to hit the tumor and spare the optic nerve, as well as spare the other eye. And so the reason you need to know all of this is we have 2 things we have to worry about: radiation optic neuropathy and radiation retinopathy. Radiation retinopathy looks just like diabetic retinopathy: hemorrhages, neovascularization, ischemia, cotton wool patches. Radiation optic neuropathy usually is retrobulbar optic neuropathy. The nerve looks normal initially and then turns pale. And the key and differentiating feature is on radiation optic neuropathy, enhancement of the optic nerve. Sometimes with enhancement and enlargement of the nerve of the chiasm. And in radiation retinopathy, we're going to do fluorescein angiogram to look for the small vessel ischemia. And as I said, looks like diabetes. So you need to know a little bit about radiation therapy, the difference between stereotactic radiotherapy and stereotactic radiosurgery versus whole brain, how intensity modulated radiotherapy allows us to conform the basis of the isodose curve to the lesion then of interest, and the side effects, which normally occur 12 to 18 months later, of vision loss secondary to radiation optic neuropathy versus radiation retinopathy. Radiation retinopathy looks like diabetes. Radiation optic neuropathy looks like optic neuritis with enhancement of the optic nerve. The treatments for these conditions are not that great. Hyperbaric oxygen has been used, steroids, Avastin, nothing really works. The key is to make the diagnosis, get the record, and talk to radiation therapy.